Doctor, please start.
Yes. Good morning, everyone. My topic for presentation is comparative analysis of Femtis M Plus versus the panoptic storic multifocal IOL. So modern cataract surgery has evolved into a refractive procedure driven by advanced intraocular lenses like the multifocal intraocular lenses, which promote spectacle independence by providing good vision at all distances. Trifocal intraocular lenses, they improve the intermediate vision by providing a third focus. The Femtis M Plus IOL is one such IOL which has a unique clip haptic design which ensures capsulotomy fixation, and it has asymmetric refractive optics with varifocal technology. Another IOL in this category is the panoptic storic IOL, which has a unique diffractive structure which allows high light utilization and is designed for implantation in the bag. So the aim of the study was to analyze and compare the clinical outcomes and rotational stability of these two presbyopia correcting toric intraocular lenses. So it was a prospective, randomized, comparative, two-arm, single-center, single-surgeon study with 120 eyes in each group, and a 3-month follow-up data was available. These were the inclusion and the exclusion criteria. So complete preoperative ocular examination was done, followed by which all patients underwent femtosecond laser-assisted cataract surgery. The Femtis M Plus IOL was implanted with anterior capsular fixation, while the Panoptix IOL was implanted in the capsular bag. Both the lenses were positioned at the desired axis using the IntelliAxis technology by the Lensier, which creates two nubs on the capsulotomy margin. This is an image of the capsular axis nubs. Post-operative follow-up was done at day 1, 1 week, 1 month, and 3 months. Coming to the results, at post-operative day 1, the uncorrected distance visual acuity was significantly better in the Femtis group as compared to the Panoptix group. However, at post-op 3 months, the uncorrected distance visual acuity was comparable in both the groups. The spherical equivalent was found to be significantly better in the Femtis group, with 100% of the patients achieving a spherical equivalent of plus minus 0.5 diopters as compared to 98.3% patients in the Panoptix group. Refractive astigmatism was found to be better in the Femtis group, where 88.5% patients in the Femtis group had a refractive astigmatism of less than 0.25 diopters, as opposed to 76.7% patients in the Panoptix group. Uncorrected near visual acuity was found to be good and comparable in both the groups, while intermediate vision was found to be slightly better in the Panoptix group, but this was not statistically significant. Rotational stability was found to be significantly better in the Femtis group. One patient in the Panoptix group had an IOL rotation of more than 10 degrees, as opposed to the Femtis group, when none of the patients had an IOL rotation of more than 5 degrees. Defocus curves in both the groups was found to have good and comparable vision at all defocus points. Contrast sensitivity was found to be significantly better in the Femtis group as compared to the Panoptix group at all spatial frequencies. Dysphotopsia and patient questionnaire showed that a higher percentage of patients in the Panoptix group reported of glare and day and night halos as compared to the Femtis group. And vision satisfaction at post-op 3 months showed that the Femtis M Plus scored better in terms of night vision, while the Panoptix scored slightly better in terms of intermediate vision. So to conclude, both the IOLs, they deliver excellent uncorrected distance and near vision. The Panoptix toric IOL offers superior intermediate vision. This is because it incorporates an intermediate focal point of 60 centimeters. And the Femtis M Plus offers better rotational stability and lesser dysphotopsia. This is because of its unique clip haptic design with anterior capsular fixation and smooth transmedial surface transition. A higher percentage of Femtis patients achieve post-operative astigmatism within plus minus 0.25 diopters. So personalized patient selection remains the key to optimizing visual outcomes and overall satisfaction. This is a picture of the Femtis M Plus lens with its clip haptics, 2 placed longitudinally and 2 of them placed latitudinally. And this is a video which shows the attachment of the Femtis M Plus lens to the anterior capsulotomy margin with the help of its unique clip haptic design. This ensures excellent rotational stability at all post-operative visits. Thank you. Thank you so much. Thank you, sir.
Yes, we start with the semi-final. Dr. Kaushik Murli is going to present his paper, Vision in Box Novel Portable. चल ही नहीं रहा। tricolor chart to screen suppression in school screening. Dr. Koshik Murli, please. Yes. Kindly adhere to time, and since we are already 40 minutes late, so we'll go quickly. If anybody is exceeding time, I will stop immediately.
No, the timer is showing 8 minutes. Actually, it should be 5 minutes.
5 minutes.
Yes, please change it.
Make it 5 minutes, please. Timer 5 minutes.
Respected judges, seniors, and colleagues, I'm here to present our novel portable tricolor chart that we've developed to screen suppression in schools. What we are trying to solve is a problem, if you look at it globally, a problem that would affect the entire population of Afghanistan, Sri Lanka, Nepal, and Bhutan. What makes it even more complex is that in developing countries such as ours, children get their first eye test possibly not earlier than the age of 10, and there is a skew in terms of the number of ophthalmologists available. Most children's screening programs are dependent on teachers. They are overworked, and often most of these are only visual acuity focused. So we look to construct and validate a portable chart that incorporated the ETDRS and the dichoptic principles to look at both suppression as well as looking at monocular visual acuity binocularly in children. So we created these three charts. What you see on the three screens are example of a single optotype line where two screens had two red, two blue, and one black letter, and the third screen had three black, one red, and one blue letter, essentially 5 letters of each color. So what we did is we built it using a monitor with an Android box and put it in a trunk box because it would make it rugged and we could easily carry it out. We also attached a UPS supply so that we were not dependent on electricity going off. We validated this in a school screening program in a population of about 1,000 children, where we looked at the logma visual acuity, we confirmed it, and once we looked at suppression that we recorded, we also confirmed it using a Worth 4 dot test. So based on the distance of the Worth 4 dot test, the size of the suppression scotoma could be recorded, and we correlated that. So this is a video to show the principle, like we would do a Worth 4 dot test with a red and green glass, where immediately you see that where the child is suppressing, they don't look at it. We included children between 8 to 15 years who are verbal in knowledge of English alphabet, and data was analyzed. As I mentioned, we looked at around 1,000 children with a mean age of 11 and a half years. We found a high positive correlation between visual acuity measurements, and there were limits of agreement were very similar both for the right and left eye, although we recorded the vision binocularly. 14 children showed suppression scotoma, both using the Worth 4 dot and the digital eye chart. And sensitivity was 93% and specificity was 99%. We had one false positive and one false negative. We also were able to correlate the size of the suppression scotoma. School-based vision screenings are known to be effective and cost-efficient. Teachers often prefer to conduct using visual acuity, and there is recent research to show that suppression possibly is the primary cause of amblyopia, making it more important for us to screen for that. Although in this particular study we use letter optotypes, the same format can be used with numbers and symbols so that we can use it both in pre-verbal children as well as in illiterate population. We did look at the Worth 4 dot test. We can quantify it in clinic based on the size it sees and then converting it to log degrees. But this is very imprecise and time consuming and subjective. There is technology available in terms of apps that are there, but again, they repeatedly give the same stimulus to the child, changing the size. And again, there can be some amount of bias when children report it. Our results were very similar to detecting amblyopia as reported by Schmidt et al. Our chart is very novel in that it simultaneously tests both monocular and binocular visual acuity and also helps us to look for any suppression scotoma that the child may have. It essentially streamlines the entire testing process, and since we don't ask the child to cover one eye and they're using anaglyph glasses that are colored, we did see a lot of interest among all the children who actually volunteered to be a part of this test. In conclusion, Vision in the Box is a novel alternative providing consistent, reliable, simultaneous visual acuity measurements and can screen for suppression, and we hope that will become an integral part of all school eye screening programs. From a financial disclosure standpoint, we filed for a provisional patent for this idea.
Thank you very much. Next speaker, please. Dr. Usha R. She is going to present vision solvage in retinoblastoma in 10-year clinical review. Dr. Usha, please.
Retinoblastoma is the most common primary primitive neuroectodermal intraocular malignancy, incidence being about 1 in 15,000 live births. Advances in the treatment has changed the outcome for retinoblastoma, improving both the vision and long-term survival. If the tumor is confined to the globe with multimodal treatment strategies, 90% of the children survive with preservation of vision in at least one eye, even in bilateral retinoblastoma. High-dose chemotherapy, salvage chemotherapy, and intravitreal melphalan have almost replaced radiation. Following the life, globe and vision salvage has been a major objective. Visual outcome in retinoblastoma is attributed majorly to the tumor location within the retina, mostly the macular involvement. We retrospectively reviewed the retinoblastoma case files to see the outcome of vision in deceased salvaged eyes and also to predict the factors impacting the visual outcome. So all children diagnosed with retinoblastoma in the Ocular Oncology Unit, Arvind Eye Hospital, Madurai, from January 2004 to December 2024 were reviewed, and the inclusion criteria were children with disease-free and provided the last clinical follow-up till January 2025. Exclusion were children who underwent enucleation, children lost to follow-up, treatment defaulter, died during treatment, and follow-up. So from 2004 to 24, 823 patients registered, all initiated on treatment in-house, 649 completed treatment and are under follow-up, 71 defaulted and 103 died. The range of age of presentation was from birth to 60 months of age. Of these 649 children who completed the treatment and are under follow-up, 226 patients were treated without enucleation, of which males were 97 and females were 129. Unilateral were 17 patients. Bilateral were 209 patients, of which one eye was salvaged. Among the bilateral patients, 23 had both eyes salvaged. In total, 252 eyes of 226 patients were analyzed for the visual outcome. So there were 84 in Group A, 66 in Group B, 56 in Group C, 27 in Group D, and 19 in Group E. There were various modalities of treatment which ranged from VEC alone or VEC plus CSA, VEC plus CSA with local therapies like TTT, cryo, VEC plus CSA plus radiation, VEC plus CSA plus intra-arterial chemotherapy, and only TTT for some small lesions like Group A. So about 70% of the patients had chemotherapy, 24% had VEC with CSA, and there were a 6% without chemotherapy. The tumor location, total patients were 226, RB with macula and disc involvement were 87, RB elsewhere was 139. So the vision improvement ranged from 6.6, 121 patients had 6.6 vision, 24 with 6.9, 23 with 6.12 to 6.18, 20 with 6.24 to 6.36. There were a few with light perception and hand movements. Now I'll quote a few examples. 8-month-old female with bilateral retinoblastoma, group right eye group E, left eye group D, right eye post-enucleation. There were several sittings of chemotherapy, intravitreal and IV. Left eye had showed a regressed RB and the vision was 6.24. This is in a bilateral, one eye was salvaged. Both eye vision salvage and bilateral RB. 3 months male, premature baby, came for ROP screening. Right eye showed group B, left eye showed group A. There were multiple sittings of chemotherapy and TTT given. Genetic testing showed a de novo germline mutation. Vision both eyes affixing and following. Patient is on regular follow-up. Vision salvage and unilateral RB as well. 7-month-old female presented with a child. The father had, there's a family history of RB. So they came for a routine screening. Right eye showed group B RB. And the genetic testing showed no mutation. Vision in the right eye was 6.36 and left eye was 6.6. Now, here is another patient where the mother of the patient had retinoblastoma bilaterally enucleated at the age of 3 years. Patient was 9 months old And right eye showed group C, left eye showed group E. Genetic testing showed a splice site mutation, and the vision in both eyes were right eye 6.6 partial and left eye 6.9. So good visual outcome by early detection of RB. Father had enucleated right eye due to retinoblastoma at the age of 2 years. So a routine screening was done for this particular patient who had a group A suspected RB. Left eye also had a group A. So patient underwent treatment, and a genetic report was also.
Thanks a lot.
Thank you very much.
I just have one question.
Yes, sir.
Why did you choose Community of Health to put up this paper?
So the implications are multifold.
It is not mentioned here.
The
The choice is because it looks very odd. It has no link with the Community
So,
of Health
if
kind
I-
of.
if
It
I-
is not a survey. You are showing the cases, this thing.
So
So
the-
I am little confused.
Yes, I will explain.
No, thanks. Thank you very
Okay,
much.
so thank you very much.
It's just a part because it has come to my mind. I'd ask others also.
Yes, sir, because it has a
It
huge.
is up to the wisdom of the scientific committee to choose it. I am no one to comment on that. But since it has come, so I had asked you that.
So because it has a
So
huge.
we will start with
Thank you. We
the
start with
community
the-
ophthalmology 3.
आप नाम बुलवा
I invite Dr. Kavita Bhatnagar. She'll be talking on burden and depression in caregivers of patient with visual impairment.
Before Dr. Kavita begins his start his talk, all speakers as per the list are here. Dr. Riya Utpal, Dr. Gotke is very much here. Dr. Pragya Sharma, Dr. Pragya Sharma, Dr. Pooja Khamar. If they are not here, we will not allow them to participate late because it's already 1 hour late. Let it be very clear. Means from beginning I am making it clear. If somebody drops in at 10:30 and asks for it, will not entertain. What do you say, sir? Agreed. What is your views? Dr. Sukriti Gupta. Dr. Sukriti Gupta, no? See, the session started at 9:10.
So should I start? Yeah? Okay. A very good
already
morning
45
to
minutes
all. At the outset, I would like to thank the organizers for giving me this opportunity. I'll be sharing our work on burden and depression in caregivers, the unsung heroes of patients with visual impairment. The research question was, do the caregivers of visually impaired patients face burden and depression leading to emotional, mental, social, and financial burden? It was a cross-sectional observational study of caregivers of patients with permanent visual impairment, category 3 onwards. So these are the categories. The sample size was 270 caregivers of 109 patients. We excluded all those patients with other severe disabilities, those receiving financial compensation and those unwilling to give consent. We used 2 types of questionnaires, caregivers burden scale, Zaret's caregivers burden scale for burden, and Center for Epidemiologic Studies depression scale to study depression. Here we can see the association of level of burden with different variables like visual impairment of patient, amount of care given in duration per day had a noteworthy association. Gender of caregivers, the female caregivers had more burden. Educational status of caregivers, again uneducated caregivers face more burden. Relationship to the patient, so parents or spouses as caregivers face more burden, and caregivers of non-working patients, probably the entire financial burden was on caregivers, so they faced more significant association. And illiterate patients had more significant association. Now coming to depression with different variables, again, married caregivers faced more depression. Female caregivers and looking after female patients, they faced more depression. Nuclear families, patients, caregivers living in nuclear families, they faced more depression. And duration of care again increase the level of severity of depression and all. So the take-home message, as I said, so I'm trying to finish it fast. 54.07% of caregivers experience mild to moderate burden, 42.60 face moderate to severe, and 3.3% had a severe burden by Zarit's caregiver burden scale. 18.15% had mild to moderate depression, while 11.85% had a possibility of major depression, going into major depression needing psychiatric consultation. Now, as I told, duration of care, because I think with time, I mean, your own physical and mental well-being suffers and increasing financial burden, so they face more depression over increasing duration. Female patients probably have to do a lot of multitasking, female caregivers, so they faced more burden and depression. Illiterate caregivers, probably they struggle to effectively communicate information to the patient and to the healthcare providers, so they face more, frustration and burden. Employment, if patients are entirely dependent on the caregivers, they face more burden and depression. Parents and spouses often shoulder primary caregiving roles with strong emotional attachments and deep-seated relationships with the patient, so they faced more depression and burden. With marriage, increased responsibilities and stress associated with caregiving, coupled with managing household tasks and maintaining relationships with spouses and family members, along with strain of fulfilling multiple roles simultaneously, probably led to statistically significant levels of burden and depression to severe grades. So to conclude, these findings highlight the need for tailored support interventions for caregivers of visually impaired individuals, which is still a neglected field. Many people have studied, burden and depression of caregivers with other physical disabilities, but with visually impaired patients, there are hardly any studies available. So they need, tailored, approaches for counseling, counseling skills, financial support from NGOs and government, and some recognition in some form by, say, government, NGOs. We can have, these cultural nights for them. Thank you. So thank you. Caregiving leaves its mark on us, whether or not. Thank you.
Thank you, ma'am. It's a good paper.
Dr. Riya Utpal is not here. Now I invite Dr. Parikshit Gupte for his talk on prevalence of blindness and visual disability among 50 years and older population of Nepal.
This is not my presentation, sir.
Pardon?
No, no, yeah.
So while he is getting ready, I'd like to know if Dr. Pragya Sharma is here.
Sir, I have just loaded it now.
Pragya Sharma, Dr. Pooja Khamar, Dr. Sukriti Gupta, Dr.
I
Vittal Nayak. With you are? You are which paper? You want to present which paper?
पर यहाँ नहीं दिख रहा है ना सर, अभी तो लोड किया हमने.
But
कोई नहीं सर,
in
मैं यहाँ
the
से लगा.
direction it is written, no change in presenting author is allowed. You can present, but it will not be considered for competition. If that is fair for you, then you can present. You can present it, only it will not be considered for competition. Sir, are you ready?
So just a minute, ma'am. I just loaded it, but they can't find it. Sir, can you put it on, please? Respected chairpersons and judges, distinguished audience, I'll be speaking on the prevalence of blindness and visual impairment among people 50 years and older in Nepal. It's a RAP survey. This was to ascertain the causes of blindness and SVI in Nepal in all the provinces and look at age, gender, and province-based prevalence so that we can decide and implement policies to reduce the prevalence of blindness. It's the first time that since Nepal from monarchy became a democracy and the 7 provinces were formed, we are trying to find out from each province what it is the level of blindness. So this was the sampling and data collection done. It went on for 3 years because there was COVID in between. And this is the response rate from each province. And as you can see, there is almost a 98% response rate. If we look at the age and sex province estimated, then the prevalence of blindness in Nepal is just 1.1%, of severe visual impairment 1.7%, and mild VI 10.3%. And if we will look at by province-wise, then to our surprise, the provinces that are there in the plains, the Madhes province and the Lumbini province, they have almost double the prevalence of blindness than what it is there in the mountainous region. This was a surprise to us also, because the Tarai region is where all the major eye care centers are located, and we thought higher up in the Himalayas, there would be more UV radiation and therefore more cataract blindness. So this is the prevalence of blindness and visual impairment in Nepal, and as you can see, it's more in the Tarai region. We also looked at this prevalence and compared it with previous studies in Nepal. So in Nepal, about 25 years ago, the prevalence was 5.3%, and now today it is just down to 1%. So all this effort that has been made in last 25 years has really reduced the prevalence by almost 4 times. If we look at it, and these are wonderful studies from the RP Center with the RAB India studies, here also we find that the prevalence in Nepal is lesser than the prevalence in India, and especially if we look at the surrounding states, Uttar Pradesh, Bihar, Uttarakhand, Jharkhand, and West Bengal. Again, when we look at the causes of blindness and visual impairment, for blindness, the commonest cause is cataract. For severe visual impairment, it is cataract and posterior segment things. But in moderate visual impairment, along with cataract, cataract surgery complications is also a cause of blindness. And of course, for mild visual impairment, it is refractive errors. So if we see causes of blindness, mostly cataract. For causes of severe visual impairment, again cataract. But when we look at causes of mild visual impairment, it is refractive errors. So this is similar to what we have seen from other Southeast Asian countries. So I would like to conclude by saying that the prevalence of blindness in Nepal has greatly reduced over the past 3 decades. So all the work done by the NGOs and all the ophthalmologists and the healthcare workers has borne fruit. There is a very small gender difference, which is great because people think that in Southeast Asia, there is a huge difference between male and female blindness. That was not the case in Nepal. Cataract is still the commonest cause of blindness and SVI, perhaps due to the high UV exposure in Himalayas, and refractive errors is the commonest cause of mild and moderate VI. Retinal causes are on a rise, and the Tarai region, which has the most eye care centers, which has the largest population, has almost double the prevalence of blindness, so more work needs to be done there. So this is the message that we had, and I would like to acknowledge all our partners who helped us in this study. It's a beautiful country. It's a country where a lot of work has been done by the Nepalese and the Indians and the Indian Army, and it's heartening to see that the prevalence of blindness has gone down so much. Thank you.
Thanks a lot. How this study was conducted, the sample size and all? I think I missed those details.
So we have the RAB software. So the RAB software looks at the sampling frame.
Was it a epidemiological survey
it is
or
going,
the hospital-based?
No, sir, it's going to the population. So 50 plus people, they are made clusters of 1,000. Dr. Suraj here is an expert in doing it. So the RAB methodology, which is followed by the RAB India or RAB.
How much was the total sample size?
So here you can see the total people examined were 32,565 who are more than 50 years. So in the, yeah, sir.
No, sir. Thank you. Thank you very much.
So what explains the last point in your conclusion? It's a very nice study.
Thank you, sir.
The last point regarding the prevalence, which is more in the Tarai areas.
So one of the reasons is perhaps the Tarai, with this is not done with the GDP comparison. So perhaps the Tarai is a poorer region. So we think that in the Tarai region, perhaps because it's easier in the plains, and the Tarai region has centers, but then half the population that the Nepal centers serve are from the Indian states of Uttarakhand, UP, Bihar, Jharkhand, and West Bengal, Assam. So with just more work needs to be done. We thought we've done a lot, but no.
Okay, thank you.
Thank you,
Thanks a
sir.
lot. Thank you very much. Dr. Ria Utpal is here. Yeah, I think she won't.
Sir, I'll just remove my pen drive.
So you need to sign here.
Yes, sir.
Dr. Pooja, you are too late. Session started at 9 o'clock.
Need a pen?
Dr. Pragya Sharma. Dr. Pragya Sharma. Dr. Pooja Khamar.
Can I start? Very good morning to all. At the outset, none of the authors have any financial disclosures pertaining to this study, which I'm going to present. So, keratoconus is an inflammatory progressive corneal disease characterized by corneal steepening and thinning, and the incidence of keratoconus in India is now 20% in the population, what we see, which leads to blur vision due to irregular astigmatism and defective stereopsis, which does affect the poor quality of vision and the binocular vision anomalies, which does affect the patient mindset also. Now, we do have treatment like corneal collagen cross-linking in early cases and corneal transplant in advanced cases. However, the outcomes sometimes are not up to the mark with progression of the keratoconus disease, corneal haze post cross-linking, excessive flattening of keratoconus leading to vision abnormalities and graft failure. And this can affect the visual quality of the patients, and sometimes the post-crossing outcomes may fail. Now, the challenges faced in keratoconus management is that we have to have an invasive procedure at this point of time, which can be expensive. There can be paucity of grafts and also emotionally burdensome, especially in children. So now if we look at the keratoconus definition, it is progressive and traditionally it was non-inflammatory, but with increasing reports, it has been suggested now that there is a low-grade chronic inflammation and oxidative stress, which may play a key role in the pathogenesis of the disease, leading to stromal thinning and affecting the vision of the patient. And whenever there is inflammation and we don't treat the inflammation, the collagen which is there in the corneal bundles, it starts getting degraded and there is progressive loss of this collagen bundles, which leads to progression of the disease and thinning of the cornea. So the key here is inflammation for this disease. So now the time has come to treat the root cause, and trehalose plays a very important role because it promotes the autophagy and reduces the oxidative stress due to inflammation in the cells for this patient. So what we did was we started with the HC cell line test. This was done in the lab on the corneal epithelial cell lines, where you can see when we inject the trehalose on the desiccation stress model, these are the cells which are stressed, and these are how the healthy cells should look like. When we treat the cell lines with 6 minutes of 6 hours of trehalose, the cells start coming back to life, which you can see here with just 6 hours of treatment. And also, when we did the corneal stromal test with the corneal fibroblast, you can see in the inflammation there is absence of totally red color, which is the lysyl oxidase. And when you treat the inflammation with trehalose, you can see that the red color is coming back, which is again the lysyl oxidase and the collagen fibers, which is coming. So our question was, can the non-invasive collagen modulation decrease the need of a surgical intervention? So we took 540 patients. We did entire diagnostics to see whether it is normal or not. And one group was treated with placebo with 180 eyes, the second group with trehalose, and the third group with trehalose and cyclosporin. And this is how we randomized and planned the treatment accordingly. Now, the group which got the placebo treatment, in that group, 74% of the patients progressed. The group which got trehalose patients, only 12% progressed, and the group which got trehalose plus cyclosporin, only 6.6% of the patients progressed. And this is just with the treatment of drops. You can see that you can see a flattening in the cornea without any cross-linking, which does show the effect that the drops can act as good as the cross-linking itself. And you can see the stabilization and flattening on Kmax and K-mean value also. And
Where
the
is
TCT
where
is
is
also
the timer actually? We need the timer. Because presentation from laptop is not allowed in free paper session.
Ma'am, I have uploaded, but it's not come.
Okay, thank you very much. Your time is over.
Sir, 1 minute.
Dr. Sukrit Gupta.
Ma'am, 1 minute is.
No, it's okay. We have given you full time. We have given you 5 minutes. Everybody is going like this only. If you are exceeding, we are not allowing. Dr. Sukriti Gupta. Dr. Nayak Vittal. अच्छा, but her name is bold, है ना? No, no. See, the reason is ना, ये जो chief and presenting author, same. अभी इसमें जैसे इनके हैं, तो इसमें इनका बोल्ड किया ना इन्होंने.
तो वो है, उन्होंने बोला कि we cannot come, so she will
Yes,
present.
she is Apurva.
She is Apurva. She will present, but हम लोग consider
Yes,
नहीं
yes.
करेंगे competition.
You won't be considered for competition. इन्होंने उसको दिया होगा ना, but they should have informed.
This will be not considered for. नहीं वो तो ठीक है सर, but we will not mark.
Yes.
अच्छा ठीक है.
लोड हो गया इनका. ये शो नहीं हो रहा है. डॉक्टर अंचल त्रिपाठी. डॉक्टर अंचल त्रिपाठी, is she there? डॉक्टर एफ तरन्नुम. डॉक्टर तरन्नुम. डॉक्टर अंकिता ऐश्वर्या. अच्छा ठीक है.
Good morning, everyone. My name is Dr. Apurva B. Kelgar, and I'll be presenting a paper on behalf of Dr. Vittal I. Nayak on a study to determine relationship between lid temperature, Schirmer's test, and T-BUT in normal and dry eye patients. We see that dry eye is a very common disease. It ranges from 5 to 50% worldwide, and the impact of dry eye disease per se is beyond vision. It mainly impacts the quality of life, which is quite comparable to the medical conditions like severe angina and also hospital-based hemodialysis. And physicians diagnose these diseases by various tests, signs and symptoms like T-BUT and Schirmer's test, and we use infrared thermography as a quick non-invasive test to screen for dry eye disease. This study has been supported by a study conducted by Arbu et al. On lid temperature and of ocular surface and periorbital regions of Sjogren's evaporative and aqueous deficient dry eyes relative to normal, noting the differences between Sjogren's, EDE and ADDE. The aim of the study is to determine the upper lid temperature, Schirmer's test, T-BUT in normal and subjects and dry eye subjects, and analyze them and look for correlation. The study population was 100, out of which 50 patients were of dry eye and 50 were normal patients attending the OPD, and also the patients who were studying for long hours in library. It was done in Bangalore. The study duration was one and a half year, and the type of the study was prospective cross-section study. Ocular lid temperature was measured using F82 Beer's non-contact infrared thermometer by asking the patient to close the eyes, and the instrument was held perpendicular to the area of interest, about 1 to 1.5 inch away from the lid. The patients included were aged between 20 to 50 years, and patients having the symptoms and signs of dry eye, and who had the exposure to VDT for more than 4 hours per day, continuous 4 hours per day. Exclusion criteria was obvious ocular inflammations like episcleritis, conjunctivitis, chronic usage of eyeliners, kajals, and usage of medications which cause dry eyes like pilocarpine, timolol, and steroids, and patients who were allergic to fluorescein. Statistical analysis was put forward in Microsoft Excel, and various tests were done using chi-square test, independent t-test, and correlation was done using Parsons correlation test. And in the results, frequency distribution in the study was about 48% were less than 25-year-olds, and more than 52% were 52 people were more than 25 years. And there was no statistical differences between the males and females. And Shermer's, Tibet were correlated to the existential studies. And lid temperature, average lid temperature amongst the normal and the dry eye, there was a difference noted of about 0.5 degrees C, and the results were analyzed, and the sensitivity and specificity for Shermer's was about 90% and 83% respectively. And results, sensitivity and specificity for lid eye temperatures were amongst the normal and the dry eye were noted, and sensitivity was 72% and specificity was 78%, and having the positive predictive value of 76.5% and negative predictive value of 90.6%. An ROC curve was made for eyelid temperatures amongst normal and dry eye, and it was noted that the graph fell more on the sensitive side of the graph. In discussion, our results demonstrated the importance of Shermer's 2 and Tibet assessing the tear film stability in line with the studies and findings with the studies by Chaurasia et al. And additionally, eyelid temperature was significantly higher in dry eye patients, suggesting its role as a potential biomarker for tear film instability. Our findings corroborate with those of Lee et al., who reported increased eyelid temperatures following external heat application. Furthermore, body temperature variations between dry and normal eyes were statistically significant, supporting the notion of local temperature fluctuations. On conclusion, our study established a strong inverse correlation between ocular lid temperature, tear film stability, reinforcing the diagnostic utility of thermography.
Thank you very much. Thanks a lot. Please come.
She is the last presenter.
Any other speaker is left? So she is the last one.
Very good morning, everyone. So I'll be presenting our work on comparative study of 4-week versus alternative treatment duration for ocular cysticercosis. No financial disclosure. Well, ocular cysticercosis is one of the preventable cause of blindness. The mainstay of medical management is albendazole combined with the corticosteroids. When we had a literature review, we found that there are studies which have used 2-week, 4-week, and the 6-week regime. However, till date, there are no randomized controlled trial which have compared these different regimes for ocular cysticercosis. So the aim of our study was to compare the efficacy and safety of 4-week, 2-week, and 6-week treatment regimes. Our primary and secondary outcome measures were the following. Methods. So we did a randomized controlled trial study. After ethical approval, all patients underwent ophthalmological examination. MRI of the CT scan and along with the B scan was done in all the patients. Baseline blood tests were done. We included all the naive cases who were clinico-radiologically confirmed cases of extraocular cysticercosis. However, we excluded the patients who had intracranial or the intraocular extension. The rest of the parameters are enlisted. So we did a single blind randomization where 76 patients were assessed for eligibility, 16 declined to participate, and 60 patients were randomized to 3 groups, each having 20 patients. In group A or 2-week regime, 1 patient was lost to follow-up and 19 were included in the analysis. In group B, 3 patients discontinued and 17 were included. And in group C, 4 patients discontinued and 16 were included in the analysis. Coming to the treatment regime, well, all the 3 groups have received albendazole in the dose of 15 milligram per kg per day in 2 divided doses along with the prednisolone. For group A, it was for 2 weeks. For group B, it was tapered in 4 weeks. And for group C, it was tapered in 6 weeks. Coming to the results, so we had 52 patients with a mean age of 21 years and a male preponderance. All cases were unilateral with a mean follow-up of 19 months. If we look at the baseline characteristic of all the patients, it was nearly comparable. However, in our series, the most common presentation was ptosis, followed by restriction of extraocular movements, diplopia, conjunctival congestion, and proptosis. The size of the cyst ranged from 5 to 15 millimeter, and 66% of the cysts were attached to the extraocular muscle, and in 34% of the cases, it was a subconjunctival cyst. The most common muscle involved in our series was superior rectus, followed by medial rectus, lateral rectus, and the inferior rectus. Coming to the primary outcome measures, so if you look at the decrease in the proptosis, it was significant in all the 3 groups. Improvement in palpebral aperture or decrease in ptosis was also significant in the 3 groups. However, the reduction in diplopia was significant in the group C or the 6-weekly group. And the cyst reduction, it was significant in both group B as well as the group C groups. Coming to the secondary outcome measures, well, the side effects were mild and reversible. 2 patients in group A had recurrence. Let's have a look on few of the cases. So this was a 7-year-old child who presented to us with a gradual progressive right eye ptosis since 1 month with a superior rectus involving cysticercosis. She underwent 2-week therapy, and at 27 months of follow-up, there is no residual lesion. This was a 15-year-old girl who presented to us with pain, swelling, and redness in the right eye since 2 weeks with a subconjunctival lesion with a congestion. And on MRI, there was a medial rectus involvement. She underwent 4-week regime, and at 13 months of follow-up, the subconjunctival cyst has completely resolved. However, you can see that there was a residual cyst which was still present in the medial rectus, but it was stable even at the 13 months of follow-up. This was 14-year-old male who had gradual progressive right eye ptosis with diplopia since 2 months, and he has restriction in the upgaze. There was superior rectus involvement on the MRI. He underwent 6-week therapy, and at 29 months of follow-up, there was mild residual ptosis. However, the movements have become almost normal, and there was a small fibrosis which was still present in superior rectus. If you look at different study, coming to the discussion part, so whether it was 2-week, 4-week, or 6-week, we found that the 6-week therapy had a better improvement in diplopia compared to the other groups. However, the residual proptosis, ptosis, and recurrence rate was nearly symmetrical in all the groups. So to conclude, 4-week regime is optimal for symptomatic relief. 6-week regime is recommended for better resolution of diplopia. However, tailoring of treatment to individual symptoms is essential. The limitation and future direction, well, the sample size definitely was a constraint in our study. We need a larger trial. However, future directives are intended to create a better and safer lifestyle with primary preventive measures. Thank you.
Thank you. Good slides.
On behalf of all office bearer of this session, I thank each and every one of you to be here. For the next session, office bearer must be here, and we have been given 45 minutes late this session, but somehow we are able to finish it because most of the people were not present, and we managed the time. So time is very important. One should adhere with it. Thanks a lot for joining us. Thank you very much.